I had also a question about the Supreme Court cases, if you were interested in those. And there were two, I don't know, there were two cases that we had before the Supreme Court. And the first one was actually started in Omaha, Nebraska, by the Attorney General. They passed a law in Nebraska that said it was illegal to remove a fetus partly from the uterus before killing the fetus, and then deliver the rest of the parts, which would kill the fetus. Okay, and they promoted this as a late-term abortion ban because you probably maybe heard the 3 minutes before birth that we're stabbing the baby in the back of the head with scissors, and that's actually was a speech given by one of the, I can't remember the doctor now, that was a U.S. senator that gave that speech. But in reality, if you think about an abortion, there isn't an abortion done that doesn't remove part of the fetus before it dies and the rest of it afterwards. So it was really, could be interpreted as a total abortion ban, or it definitely was interpreted as a second trimester ban, anything after 14 weeks. Except for the 3 or 4 of us in the country, and myself included, that were doing the fetal euthanasia on all patients over 16, 17 weeks, so that they were not alive after the first visit, so they were dead before. So the bill didn't affect us at all for our late patients, but it totally banned abortions from 12 weeks to at least 18, 20 weeks, until we could do the injection. And many physicians in the country at that time were not doing the fetal injections, so it would have severe limitations. Nobody else in Nebraska was. And we took that bill to the Supreme Court. The Supreme Court did indeed recognize that it would be a ban on second trimester and above abortions. So we won that case, and then 3 years later, the federal government introduced another almost exactly same language, except it was worded a little differently. And we again challenged that before it got to the Supreme Court. We won all the way to the Supreme Court, but we lost it in the Supreme Court. However, Justice Kennedy said that the law could only be applied to fetuses over 18 weeks. So we essentially won that case, because by then everybody in the country pretty much was doing injections on people that were over 18 weeks. So, but that's the basis for the ban. It was nothing that we were trying to protect late abortions, but we wanted to protect the 12-week to the 18-week period. Back years and years and years ago, you could do early abortions, but then you couldn't do abortions. Technically, nobody had the skills to do abortions between 12 weeks and 18 weeks. At 18 weeks, they would do the salt or the other infusions into the uterus. But no, there was, without the vacuum aspiration, it was just too much of a risk to do at DNC after the 12 weeks. So it was really trying to take everything back to the 1960s and 70s. And that's why we fought it. And it was one of the things you asked me to talk about. How I got the heroin. Yeah. And that's easy. I was working with Dr. Tiller in Wichita, Kansas from 1997 up until when he was murdered in 2009, and we were doing the second and third trimester abortions there. And after he was murdered, his wife did not want to keep the clinic in Wichita open, so the 2 women that were my associates went to work in Albuquerque. They were both from California, Southern California. And I just took my office, which we were already running. We're doing abortions to 24 weeks there, and we just extended it. And so after about 1 year, the state was they passed this fetal pain bill for no abortions after 20 weeks, which is still in effect. It is probably totally unconstitutional, but we just have been a little bit afraid to take anything to the Supreme Court right now, because you don't know who's going to go where, and they could end up we could end up much worse than we are right now. Maryland in 1992 had a state referendum, and it was good. It was the year that Clinton was on the ballot too, so a lot of liberal, a lot of Democratic support. But they included abortion rights and actually codified Roe versus Wade and Doe versus Bolton as Maryland constitutional law. So by the Maryland Constitution, abortion is protected here, and that can't be changed without a 2/3 vote of the populace. So I think we're pretty stable in Maryland for a while, and that's why I'm here. I will take questions after that. I don't think.
There were several questions submitted related to how your practice has changed and how it's been affected by recent Planned Parenthood, as well as how your life has changed after Tiller's murder, and kind of the reactions you get and how you deal with those.
Well, Dr. Tiller and Warren and sort of myself have been all, we knew that he was not the only doctor murdered. So far there have been 9 people that have been murdered in abortion practice, including 2 receptionists in Boston, a security guard in Alabama, a nurse in, I can't remember where, and I think it's 6 doctors. Anyway, but there are 9 fatalities from abortion doctors. And then another friend of mine was shot once by a sniper but survived and went back to practice, and he was stabbed by another person, and Dr. Romalis from Canada, and he still was able to go back and practice after that. So there have been numerous other assaults and attempts. So we everybody knows that we're sort of marked targets. But you can't, I don't think you can let that influence you, because, especially if you go to Virginia Tech or you work for 7-Eleven, you're also a marked target. So it's where society is today. It's not a very forgiving place. So it really has, it changed my life, financially, because with 1 of 3 docs, I had it really nice. I worked every 3rd week and had 2 weeks off. And, but the 1 week we worked 100 and some hours. So it was hard work for that 1 week, but then you had 2 weeks to play before you went back again. And that was great. That was really where we saw ourselves for a long time. But then when they closed the practice, we had to split up. So that as far as how it's affected us, it really has not changed my practice at all, because I was doing the fetal euthanasia before, and we've just continued doing that. As far as security, we had U.S. Marshal. If any of you watch the show on Sunday nights, Madam Secretary, it's sort of like you're a prisoner, and that's kind of the way it was for all the time. We had the U.S. Marshals. You couldn't leave the house unless they were there. You couldn't go anywhere unless they knew you were going there, and it was not a fun way to live. It was only that way for us for about 6 months, and Dr. Tiller had that from, I think, like 2.5 years or 3 years. And Gary Romalis, the doctor from Canada I was telling you about, the Canadian government appointed him a detail that he didn't pay for. That's just like the U.S. Marshals, but he, for like the last 9 years of his life, had constant surveillance. So it's just, that part wasn't fun, but it's nothing that would make me give up what I'm doing, because it's just each day, and I don't know how many of you have had anything to do with women that were desperately in need of an abortion, to see how life-saving and how much, there are pregnancies that were unplanned. We don't take care of those women. It's the pregnancies that are really life-threatening or psychologically unwanted, and it's just, you can't. The women know what they need, and you just have to be there for them. Anybody from the floor?
Any questions? I also have the list if people don't want to raise their hand or shy.
Okay. So I wanted to ask, what's your opinion on the upcoming Supreme Court case regarding the Texas laws for improving abortion safety and requiring doctors to have admission rights at hospitals to prevent the women's deaths?
Well, I can tell you right now that throughout the country, the universities that have the Ryan Fellowship Program, which is an advanced practice program for OB doctors in family planning, but they are trying to find abortion clinics to send their doctors to for training. So first of all, you know, the expertise for abortion, unfortunately, is not in the hospitals. I don't know, I know we have a couple doctors here from Maryland, but it's not uncommon to hear stories of women that are 19 weeks pregnant and end up in a hospital bed for 5 days trying to be induced, and then end up with a hysterectomy for a dead baby. And it's virtually malpractice, but it happens. It just happened several months ago in DC, and it happened years ago to a friend of ours in Omaha. There are many things that we learn from the docs. I mean, I'd love to have residents come because I learn as much from them as they take home from us. But it's really, to have somebody that have to be on a hospital staff. The big problem is the hospitals don't want us on the staff. You can't really be a physician on a hospital staff unless you're going to guarantee them income. If you're not going to admit, they don't want you. And I don't want to admit. When I admit, that's a problem. So just by that alone, if you can't get privileges, you can be, you know, the best doctor in the country, but if you're not going to admit, then they don't want you on the staff. So that part right there is very destructive. As far as like having hospital type requirements for the clinic, which is what they want, you know, 250 square foot surgery rooms and 6 foot aisles and 6 foot hallways. And it's ludicrous. It's just not needed. So it has to be recognized that these are purely laws to make abortion unavailable for women. It has nothing to do with physical or medical safety for the patient.
Any more questions? And since some of you are in like corners, if we could actually make a line down the center of people who want questions, so that way I'm less running around. So, have a question? No, just there we go. So could you come up, and then other people who have questions come line up as well, so there's less running. Or at least running for me.
Earlier you mentioned that you don't treat women with unplanned pregnancies, but I think you used the term unwanted psychologically, and I was wondering what that definition means and what's captured in that definition.
Okay, most of us are probably results of unplanned pregnancies. Okay, unfortunately, that seems to be the way it is in this country. However, there are pregnancies which are devastating to women's plans, and they're the women that we see. Certainly, if it was an unplanned pregnancy and they come to the office, I'll take care of them, because I see my part as a provider to provide abortions to the people that have made up their mind that that's what they need. I will not help a patient make that decision. I'll send them back to see their primary care docs or somebody in the clergy or somebody else, but that's not a decision that I think an abortion provider should make. Okay, if once you've decided you want an abortion, then I need to see you. But before that, I don't want to. And so that's what I'm getting at. Not that there are unwanted pregnancies, and I mean, it's just the product of rape. And some women get raped and they do fine with the pregnancy. For other women, every time they think about it, it's a trauma, and they relive the rape. So I'm not going to put myself in her head and say that this is a good idea or it's a bad idea. Once they've decided that they cannot stand the thought of continuing the pregnancy, that's when we want to see them.
Oh, thanks. Thank you for being here, Dr. Carhart. My question is, in your experience of practicing abortions, have you ever had an instance of an infant born alive? And if so, what protocols do you follow in those situations?
Well, I have not, because, as I said, anybody over 17 weeks in my practice, we do a fetal injection 3 to 4 days before the abortion is completed. So the baby, we know the baby's been dead for multiple days. And we do that for many reasons, none of which were to guarantee that the baby wasn't alive. I know practitioners that have had babies delivered alive. Most of them have been, the women go to the hospital in the middle of the night, and it's not been in the clinic. As far as, you know, you've read the same stories I have about Dr. Gosnell and a few other people. I don't know how much is true. It's certainly possible that it could all be true, and it's possible that maybe not so much of all of it is. But the state law requires that the baby's alive, that they be every attempt to be resuscitated, and I would certainly follow that. But it will not happen in my practice.
Thank you so much for coming today. My question is for people that are considering being future abortion providers, what advice would you give them? And also considering their scope of practice, what are some thoughts that they should think about if they want to do first trimester or second or third? What are some thoughts?
Well, I think that, first of all, when medical students for choice became a reality, I said I was kind of opposed to it. Not that they shouldn't be for choice, but the goal of having people become abortion providers because they went through medical students for choice, don't think is really going to work, because most people coming out of medical school and residency and fellowship or whatever they do are phenomenally in debt. Okay, right now abortion practice does not make millionaires. So, number one, nobody wants to come out of school, especially in an OB practice where they're on call 24 hours a day, 7 days a week. That's just not where most people are today. You have young people with families, they want to raise their children, they want time at home to be alone. My argument for medical students for choice was to expose people to abortion practice, and then hopefully when they're burnt out of doing labor and delivery and OB and gynecology and they're 55 or so, that they might cut back and come work in the abortion field. Kind of what I did, and most of the other docs that do abortions in the country are the same way. They practiced any kind of a field. We have radiologists that I've trained. We trained internal medicine people, general practice. It's, you know, I think it's a great way to give back, but to start a family and to start your life and to recover from the financial disaster of what you're doing, it's just not a very good idea. And then again, to be on call every day, every night, you know. And the other problem is, the reason I'm saying that is if you go in a big practice, your partners are going to say, no, you're not going to do abortions because we can't take that hit publicly. And as the junior member of a group, you're not going to have any say about what you do.
While waiting for people to come up, I have a list of questions as well. There's a lot of public health students in the audience, and the question was asked, what can we do as public health practitioners to improve public support for abortion and to keep providers safe?
Well, I think, you know, ideally, and I know Dr. Tiller used to say that the reason that abortion practice is the way it is today is because of the anti-choice movement. If the anti-choice movement did not exist, doctors would be doing abortions in their own office for their own patients when they needed it. The women wouldn't be trapped out 16, 18, 20 weeks trying to find somebody to help them. So the antis have really created the market, I guess if you want to call it that, the marketplace that we have today. So ideally, I mean, I would love to see it get back to the point where women were able to get care from their family doctor and not have to go anywhere else. I think that's what they deserve. But as long as people, doctors can't practice the way they know they need to, then there's going to be a need for clinics. What you all can do, I think, is to You know, I don't think that anybody here has to say I'm for abortion, but I think that you have to understand your patients and trust them that they know what's best for them and help them get whatever outcome they want. And that's really what I see, no matter whether you're in public health or what you are, or nursing or a physician. You just have to help the patients understand what's available, understand their options, and then whatever choice they make, I think they should be supported.
Hey, Dr. Carhart, thanks so much for coming and speaking to us tonight. I was wondering, I'm just wondering if your clinic provides any support, mental health support for the women who come see you and what that might look like.
We don't, but we have referral sources, and there are several groups that work nationally, telephone support. We have, at least in Maryland, and again in Nebraska, we have private practitioners that will take our patients for referral. So again, I don't like to try to mix in the abortion practice. I don't want anything where it looks like that we're trying to coerce or influence people into making a decision about what they're going to do. I just don't think that really belongs in the abortion office.
There was questions asked of what has been the most rewarding aspect of your job, as well as what has been the most challenging.
Well, I think the most challenging, is security, not just for ourselves, but for our staff and for our patients. You know, the last clinic attack in, was it Phoenix or Scottsdale? They were a patient's partner and just a passerby that were murdered. It was nothing to do with the actual patients or the doctor. So I don't know what the intent was, but that's the biggest challenge that we have, is how do we keep our patients safe? And of course, the patients don't like it that we don't let them bring cell phones in the office. But that one of the practices in some of the communities where the antis would come in the office and take pictures of all the patients and then post them on the internet so that they would be exposed that they were there for their abortions. So we don't allow telephones, and we can't allow computers. It's just, that's the hardest part of the practice. The most rewarding part of the practice is today. We had 2 patients that were 18 and 16 that were more advanced. One because of a rape and one just because of lack of knowledge, I guess. But just that when they say thanks for giving them their life back, I think that's, you know, that they would never, if they could become good mothers, they would never be able to develop themselves the way they wanted to. And if they develop themselves the way they want to, then somebody else is going to have to be the child's mother. So they're caught in a catch-22. And some parents don't want to be, some patients' parents don't want to be grandparents again, or mother and father again. They want to be grandparents. They don't want to be another second-term mother and father. So I think that's the most rewarding, is the pretty much every patient, the relief that they have. And virtually nobody is happy when they leave our clinic, but in the survey that we give them and ask them how they feel about, or what are they feeling most about their experience, and the answer is relief. And I think that's about all we can hope for.
You may have kind of answered that with the next one, but we got 2 questions asking how you've stayed so, I'm sorry, I didn't see you. Okay, yes. How you've stayed so resilient throughout the years with anti-abortion protesters.
Okay, I'm sorry.
How you've stayed so resilient over the years when faced with so many anti-abortion protesters, or
I don't know, maybe I'm just an arrogant person. I believe very strongly. I did 21 years in the military where, we woke up knowing that people were trying to kill us every day, and that was our job. So, the fact that there are a few people out there, it's, I don't know, to me, it's the rewards from what I get. The only way I could do it is from the fact that I have such good support to my family, and the fact that the patients really, really bring so much of a reward on a daily basis. It's So I think that's probably how.
Oh, I understand. Hi, Dr. Carhart. First, I wanted to say it's an honor to meet you, and I'm very glad that you came and spoke with us. I have a question sort of about telemedicine, but it requires some explanation. I'm from Texas, home of the trap laws, and it really has caused some problems. One of the restrictions is that the early abortion medications have to be at the FDA required amount, which, as you know, is nauseating, dangerous. It's caused some of the clinics in the area where I'm from to stop offering it. I'm wondering if telemedicine might be a potential way around this.
Okay, we had telemedicine in Nebraska. We were doing abortions over the internet. Well, the patients had to be at one of the offices, and we had everything had to be set up so that we could dispense the pill mechanically, but by me, I was the only one that could dispense it. But the state passed a law, and Nebraska passed a law against that. Several other states also have passed laws against it. In Maryland right now, I know one of the clinics that still does telemedicine, meaning that the doctor is not in the clinic, but they, like the Planned Parenthoods, can have 5 or 6 offices throughout the state. The patients go there and they can call into where the doctor is, and so they can hand the patient the pills. As far as the other part of that, requiring the original prescribed protocol, and right now I can tell you that the people that make the RU486 or mifeprex or mifepristone, whichever you want to call it, they are in the process of republishing the guidelines, and they're doing the studies right now to show that, unfortunately, the 3-dose pills, I mean, the pills right now, if you buy them, I think, what do you have to buy? 12 at a time, and they're almost like $1,100 for the 12 pills. So the pills are virtually $100 a piece. So if you give a patient one, that's a $100 cost. If you give them 3, then it becomes a $300 cost just for the pills. So again, their input is to raise the cost of abortion to the patient and make it less available. But the bad part is, statistically, the literature that we published in 1995 with using the 3 pills said that there's an 8 to 10% failure rate. With the new protocol that we're using in most other states, except for North Dakota, where you have to do that, they've had that law for quite some time now, we're seeing a 2% failure rate with 1 pill. And the difference is really that everybody that takes 3 pills has nausea, vomiting, and diarrhea. I doubt that they retain as much of the medication as the people who get 1 pill. We see better results, and it's forcing people to practice substandard medicine just to appease some public policymakers that have they have no knowledge about what they're talking about, but they have their desire to make abortion illegal, or unavailable, I'm sorry.
There was a question of where do you envision the future of abortion access?
Well, what I envision is all of you getting all of your friends to go out and vote for somebody that supports abortion. If you don't do that, then I think abortion will not be available in this country. In 1992, Planned Parenthood was so convinced, and I was at that time the medical director of Planned Parenthood for Wisconsin. Planned Parenthood was so convinced that abortion would not survive in the United States that we were training groups of women how to provide abortions for other women safely for the first trimester. And actually it got out to the public, of course, because we were training bunches of women. And I remember, I can't think, but somebody from ABC News came and interviewed Michael Carhart, who at that time was the head of OBG, or he was the vice president for medical affairs for Planned Parenthood nationally. And they asked him if it was safe to train women to do abortions on each other. And he replied, I think you could train chimpanzees to do abortions. It's just teaching them to take care of the problems that's the problem. So, that's about where we are today. Just, and I think that's where we may end up. And, it's I see it eventually losing the right to abortion. And then I think it's going to be the war on women will have started with that. And we lost 50,000 lives in Vietnam of young men. And I don't think it will take many years before we lose 50,000 lives of young women.
You mentioned earlier that without the support of your family, practicing the way that you have, it would be really hard. And I just would love to hear more about how your family and loved ones have supported and been impacted by your decision to practice.
Okay. Well, my daughter started working in an abortion clinic when she was 17. Not one that I owned, but she was very supportive. It was one that I worked at, but not that I had any control over. Before I decided to start doing abortions, I talked with my family at great lengths. My son was, at that time, a freshman in college, and he wasn't, he said he wouldn't be impacted that much because he wasn't there, but unfortunately his name is exactly the same as mine, so he was surprised to learn that it did impact him. And my daughter is very, very, very strongly pro-choice, and so is my wife, and thankfully, so are my parents and my wife's parents. So we were raised in that culture, and you know, it's just, I have this innate belief that we shouldn't force women to do anything that we don't force men to do. And today, a male can walk away from a pregnancy at any stage, from conception to 21 years of age, with absolutely no consequences, unless you get the courts involved. And I very strongly feel that there should be a law passed that says that any male that creates a pregnancy, either by accident or intent, is responsible for that pregnancy until it reaches majority. I just think that that should be a law. I think it would eliminate a lot of problems in this country.
I guess this question is a little bit related to that. Do you or did you ever view your medical practice and medical practice in general as inherently political?
Okay, I missed.
Do you view your medical practice as inherently political, or medical practice in general?
Well, you know, in today's world, virtually everything you do is political. You know, it's certain that politics controls my practice. I don't think what we do is political, but I think that in order for certain politicians to gain grounds, they look for the political people or populace that they want to have support them, and then they go to the radical extremes to make that their goal. So I think that abortion is greatly influenced and affected by politics, but I think so is the entire field of medicine. And, you know, I think there are people in Washington that think that they can practice medicine better than we can. So.
I have two questions. The first one you might not want to answer, so you have the second one just in case. So, as a current and future abortion provider, I also think a lot about security, and I'm curious if you're comfortable saying about some of the things that are kind of your routine. I would utterly understand if you did not want to answer that question. So my second question is, when you look back on your career as you transition to abortion care, is there anything you would have done differently?
Yes. There's one thing I wish I had done differently. I wish I had done OBGYN residency instead of surgery, and I wish I had joined the father of the clinic, the woman who owns the clinic now, Carl Stave, was actually he was the head of the OB department where I did my internship, and he kept asking me to come work at his practice, but he never told me what he did, and so I didn't do that. And now he's passed away, but I wish I had been involved with him from the very beginning. That's the main thing I miss. As far as what do we do for security, and I don't think there's anything that we don't do for security. I think the main, you know, I told Maya and Kristen, is it? That when on the telephone, that this is the first time I've spoke where people knew I was going to be here in the last 10 years. I mean, usually it just says guest speaker or something like that. And this is probably one of the most concerning venues, except you do have excellent security on campus. I did check that out. I think that even though Baltimore has a lot of political problems in the city, I think it's a very, very progressive city. And I think the people here are a lot more stable than some other communities. So that's the reason I'm here. But I think, you know, Dr. Tiller was murdered in church because that's the only thing he did every week that somebody could count on. Everything else he did was either in a closed gate community, like, you know, he belonged to a country club that was very, very restrictive, so only members could get past the front gate. He virtually never went out of his house, which was almost a fort, but he did go to church every Sunday, and that's where he was vulnerable. So I think the main thing is that you cannot be predictable. If somebody can predict where you're going to be, you're not safe.
Another question that was given was, could you tell us a little bit about your day-to-day practice as a family planning and abortion provider?
My day-to-day practice is about...
As a family planning and abortion provider.
Okay. Right now, as I said, Sundays I travel. We have a clinic Sunday afternoon from, well, we start different times just to be less predictable, but sometimes Sunday either morning or afternoon, where we do our patients that are further along. And then we do Monday, Tuesday, and Wednesday patients, again, on a gestational basis. We do early patients later in the day on every day. People under the 12-week, actually up to 14 weeks, we do it one day. As far as family planning, not this office in Maryland, but in Nebraska, I do the IUDs, I do Assure, I do Marina, and the, what do you call it, what's it, progestin.
The Depo shot?
Oh, Depo, yes, yeah. We do Depo here too. And of course, we do pap smears and pill consents. You know, ideally, we try to have everybody that comes to our clinic leave on some kind of birth control so that they have as much of a chance of not having to come back as possible. And that is one of the most important things that we put into our education program. What are you going to do so that you don't have to come back?
Well, first I wanted to ask you, you've had so many people trying to harm you and people you've worked with devoted their lives to stopping women from getting abortions. How do you try and make sense of where those people are coming from and why they feel like...
I gave up trying a long time ago. You know, I mean, I cannot believe that there's any bit of sanity into a group of 8 people that for 15 years have protested in my clinic, the same 8 people, when I've seen 3,000 patients, or 2,000 patients a year, like 30,000 patients over the course of only 8 of them have been coming, trying to put their point across that they know what's best. And I'm sure they do know what's best for them. I just don't believe they have a right to make any suggestion to the rest of the world what's best for the next person in line. So there's no way to justify them, you know. The Constitution says they have a right to be there, so they can be there.
And my other question is, you mentioned that you try to have all your patients leaving on birth control. Do you feel like in an ideal world, women wouldn't come to you and need abortions?
I think, you know, the main problem with the later term practice, the problems are fetal abnormalities. Over 24 weeks, that's about, rape, incest, and fetal abnormalities is about everybody I see over 24 weeks. Elective abortions at that stage are very, very rare and have to be very well documented and monitored there. Okay. For the earlier practice, I think it's multifactorial. It's the availability of birth control. It's the knowledge of, we still see women that don't understand how they got pregnant. They've never been educated. It's, the parents of some groups want to have the sex education left to the home, but they don't want to teach it. So a large segment, women grow up only knowing what they learned from the streets. And some of that's very good, and some of it's not worth much at all. So, we try to get them educated, at least tell them what options are out there, and hopefully have them try one for a while.
Related to that question, do you provide any services to women who have fetal demise, rather than having them go to labor and delivery?
Oh, well, we do it in, yes, we have OBGYN doctors that will send patients to us with fetal demise because, 14, 15, 16 weeks, their total bill at our clinic if they were to pay cash. And we do get insurance reimbursement for women that have indications for these problems, but their total bill at our clinic is probably less than their copay if they go to the hospital. And a lot of docs realize that, and especially in Maryland, there's one Capital Care sends us patients from a lot of their clinics just because it's financially, and plus we do everything as an outpatient instead of being in the hospital for 2 or 3 days. So it's, yes, we get a lot of referrals and we're very happy to take care of those patients.
So we've gone through almost all the questions. Do you have any last words you would like to impart some knowledge or?
No,
Unless your last call for questions.
Anybody on the floor? Anybody at all? I mean, I can talk until what, 4 o'clock in the morning.
Can you just talk?
People can't hear you unless the
Oh, I'm really loud. Can you just talk about some of the fetal abnormalities that cause women to go see you?
Okay. Right.
Did everyone hear
People in the
that?
back hear that?
Yeah, I mean, that's not
The
a
fetal
problem.
abnormalities that cause women to come to us, it's, there's some god-awful fetal abnormalities that we see. So, I think the worst ones are the trisomy 13-18 combination. Most of them are not compatible with life. The skeletal dysplasia. A good number, I mean, even Down syndrome, when you think about doing a termination for Down syndrome, and then you say, well, I saw so-and-so and so-and-so, and they've got a 13-year-old or 15-year-old daughter that's got Downs and she's doing perfect. That is the exception. There are Down syndrome patients that have multiple defects. They're not going to be born alive. I mean, they can be that bad. It's a whole gamut of things, so you can't just say you shouldn't do Downs because there's a range. And again, I think, I don't know, I could probably pull this stuff out of the computer, but it's virtually I've got a textbook of fetal abnormality diseases, I forget the name of the book, but I don't think there's too many pages that we haven't looked over for somebody that's been referred to us. It's just very, very broad spectrum. We've had, I don't know the actual syndrome, but the babies that are cyclops with only one eye, babies that have nothing, anencephaly is probably the most common one we see. If you talk about the number of patients that we see with it, that's probably our biggest referral. People that have meningoceles or they have no skull, the brain's in a sack off to the back of their body. Yeah, it's, I'm not talking about, 6 fingers. That's not the kind of deformities we're talking about. I'm talking about severe fetal anomalies. And we don't see anybody that hasn't been referred to us by one of the maternal fetal medicine groups. And if we get somebody that hasn't been seen by that group, then we encourage them to go be seen before we will see them.
Thank you for coming. So I was curious, you mentioned health literacy and lack of education, but I was wondering what the reasons tend to be that women present later for abortion, like later term for abortions, or maybe the demographic of those women.
The reason for what?
for women to come and present in late term.
In late, okay. In late term is a really lousy explanation, okay? Late term for the antis is like you're pregnant. I think most women, and we see people every day, not every day, but every week, they found out Friday that they were pregnant at 26 weeks. And that happens. And then they actually, one that we saw this week, we sent her back because I wanted her to see an MFM group. She's coming back next week. But she found out she was pregnant 2 weeks ago from a rape, that she'd obviously known that she was pregnant, but just been in denial. And then finally, when she goes and sees the high-risk pregnancy group, they do the ultrasound. Well, we knew the baby had severe deformities when we saw her here, but we just told her she had to go see somebody. And again, it's the unavailability of good health care. Women, people in the United States just don't have access, a lot, do not have access to good health care, so they put off cancers until it's too late to be treated. Putting off a pregnancy is an awful lot easier because if you're in denial, you're not pregnant. So it's easy for some women not to realize they're pregnant. You read the stories every week of somebody that goes to the hospital and has a baby but they didn't know they were pregnant. So, I mean, that happens. But it's not, and the other problem is access. In fact, another patient that we just saw from Southern Virginia down by Langley went to the family planning, or went to Planned Parenthood there, and she was too far for them, so they sent her to New Jersey, whose cutoff is 24 weeks, so she had to wait a week to get up to New Jersey. She went there to see them, and then they said, well, you're too far for us. So then she's back to see me at 25 weeks, again, with a problem. So it's just that it's a very, very broad spectrum, but I think it all comes down to the fact that most people, probably most of you in here, don't have a doctor that you see regularly. And, you know, if you have a problem, you go to the emergency room or you go to a rapid care center and they take care of your finger or whatever, but they provide nothing as far as overall health care. And it's just our whole medical system, I think, that lets these flaws keep going. If we had a well-structured healthcare system, I think most of the late-term pregnancies would be picked up much, much earlier.
This will be the final 3 questions, the people who are currently online.
Dr. Carhart, thank you for coming. In the movie After Tiller, we saw one of the providers kind of talking about the challenges of screening for patients who are psychologically prepared to go through with the abortion. And once, I guess, could you talk a little bit about, I guess, how you assess objectively, or how you try to remain objective in assessing whether or not something is, a pregnancy is truly psychologically unwanted?
Okay, again, that depends on their gestation. If they're under 24 weeks, we just have an advocacy form that we make them fill out. It basically says, you know, it asks them several ways of getting around the question, how sure they are of what their decision is, how they're going to feel afterwards, and just anything to pick up red flags that we want them to go back and talk to somebody before we actually see them. Once they get past 24 weeks, then it's a very detailed one-on-one actual telephone, either telephone call or an in-person interview with a staff member or usually we try to have one of the senior nurses do the evaluations and get totally into their, it's a total psychiatric workup to try to determine, you know, if they're going to need care afterwards. And not necessarily for the termination, that's usually not it. It's just for what they've gone through getting to the point that they get to us. But I think I have to be totally convinced that they know that this is not just the option that they need, but it's the only option that they need.
Is that mostly like a gut feeling? Sorry, is that mostly like a gut feeling, or have you guys?
I don't know, I hope we've made it a little more scientific than a gut feeling, but I will tell you I rejected people that everybody else thought we should do, and should I do that? I don't know, but I'm very, very, we pretty much drug screen everybody, and if people come to us with a history of drugs, I usually will not do them, even though they have ironclad reasons why they're there, but I tell them they have to come back, come back without positive tests. And that's one of the biggest reasons that we do it. I think that, legally, you have to have informed consent, and if they're under the influence, we can't do that. And so that's probably the people that I refuse the most, or maybe it's the gut feelings. But our staff is getting pretty good too. They all agree with what we're doing, that we just need to weed those people out and they have to come back clean. But no, I don't think it's a gut feeling. I mean, I've had people that I would probably do, but the rest of the staff thinks that it doesn't meet the qualifications, so we don't do them.
Thank you for being here. I live in Germantown, near your clinic, and I understand that your health status has come into questions a couple of times as far as exhaustion goes. So I was just wondering, since you have such a high demand, for the patients, to see if there's been any changes in your practice as far as keeping yourself healthy, as far as spreading out. Is there any regulations as far as like how many hours you can practice in a given day or anything, just to make sure yourself and your patients are healthy?
I guess I'm too old too, but I don't know. Yeah, I mean, I guarantee you that the residents that work in my clinic for a week are really happy they were there and not back at the hospital. I think there are a lot of things that some people come up with. I don't know where the exhaustion thing came from. Maybe I look tired to you today too. I've been up since, 6 o'clock this morning and still going, so, I guess, I don't think that I've ever been impaired because of sleep or exhaustion or whatever. I fly into here, but I sleep the whole 4 hours on the airplane. I'm asleep before we take off. I usually have to wake up to put the seat back up so I can go to sleep. So we can get off, they can land. But, we do spend long days, but I think there are ways to relax during the days. I'm sorry, I just don't believe that I'm exhausted, but I guess maybe that's just me.
And last question?
Well, thank you for being here and for letting us know in advance that you'd be here. So I'm wondering, are there any cases where you see it as your ethical obligation to persuade a patient to have an abortion in a case where it might be like a severe danger to the woman to not have an abortion?
I don't think that I have in the last, somewhere between 80,000 and 100,000 abortions that I've done, ever persuaded anybody to or not to have an abortion. From the very beginning of time, that's just not my decision. That's a decision that only belongs to the patient, and she's welcome to take everybody's input from around the world that she wants to. I don't think she's obligated to take anybody's input that she doesn't want to. And I just think that she has both the right and the intelligence to choose what's best for her and her family.
And along the same lines, have you ever tried to convince other providers that they should provide abortions?
I beg everybody. I still feel that what's the right answer is that everybody should offer patients in their own practice abortions. I think that's the right choice. Whether you're family practice people, Dr. Tiller was a family practice physician. Dr. Hearn in Boulder is a public health physician. He has his, he's an MD, but he's also MP, what do you call it, MPH? He's a doctor of public health, whatever that is. He's got the 2 doctors. So, but, I don't think, again, the only thing you need to know in abortion is when you're in trouble, and then you need to ask for help. So I think anybody can basically be trained to do abortions.
So we're a little bit over time, but we want to thank you all for coming and for joining us today. Once again, thank Dr.
I just want to make a general offer. You guys are only, what, an hour from my clinic in Maryland, okay? And we're open every Sunday to Thursday. If you have spare time, you want to come down, you want to meet the women, you want to go through, I don't care whether you believe in abortion or not. If you want to come visit the clinic, you're welcome, okay? So.
Thank you again. Please clean up after yourselves. This is the first year's lecture hall. And